Welcome back to Catalyst University. My name is Kevin Tokoph, and in this video, we're going to go over the diagnosis and general treatment approach for a bicipital tendinopathy, particularly the proximal kind. So with shoulder pain, they cover a lot of stuff in PT school. They obviously cover rotator cuff tears, they cover impingement, and they cover a variety of other things. We talk about labral tears, shoulder arthritis. But one thing that I find is not covered very often, it wasn't really covered in my program that much. It was mentioned, but not really covered. And it's pretty consistent with a lot of students that I've talked to and practicing PTs, and that's the bicipital tendinopathy. The reason I think this is so important is because out of all the shoulder issues that we see, I would say it's the third most common. It's a lot more common than people realize. Rotator cuff impingement, those are probably numbers 1 and 2. But I would say bicipital tendinopathies, we see these a lot more commonly than shoulder arthritis, labral tears. So it's pretty common. It's important to be able to recognize and also be able to treat. Now, generally speaking, with a bicipital tendinopathy, there is some kind of muscle imbalance. Okay? Usually does not result from an injury. There's weakness, motor control issues, muscle tightness, just general imbalance, which leads to altered mechanics and potentially overuse on the bicep tendon, and that leads to the person's pain. So let's go over how you identify a bicipital tendinopathy. The first step is understanding the anatomy. So here's the bicep muscle right here. Now, what most people don't realize is there are actually 4 total tendons. We usually think of 3. There's actually 4. We're not going to concern ourselves much with the distal ones down here, but it is important to know that there's a distal bicep tendon right here. This is the one that attaches on the radial tuberosity. This is the one everyone's familiar with. But remember, there's also another one called the bicipital aponeurosis, and this one actually attaches on the ulna. So the bicep attaches on both the radius and the ulna. Don't forget that. But what we're concerned about here in this video are the proximal tendons. There's a long head tendon, which is more lateral, and there's a short head tendon. The long head goes up this bicipital groove or intertubercular groove of the humerus, and then it curves off and attaches on the scapula, specifically the supraglenoid tubercle and a portion of the superior labrum. And then we have the short head tendon, which goes in more medially and attaches on the coracoid process of the scapula. And where you find these tendons anatomically obviously plays a role in how you diagnose which one is affected. So let's suppose you have a patient that comes in with anterior shoulder pain. If somebody has anterior shoulder pain, I've found that that almost completely narrows down your diagnosis. There's not much in the anterior shoulder that generally causes a problem. It's usually not a rotator cuff tear. That's more lateral shoulder or posterior if you're talking about infraspinatus. Impingement's really more on the top, and both of those cause this anterolateral referral pattern, which you don't really see in a bicipital tendinopathy. With a bicipital tendinopathy, it's anterior shoulder pain, and they're usually able to localize that pain pretty well. The pain is usually going to be in the bicipital groove, which is going to be for the long head tendinopathy, or in the coracoid process, so a short head tendinopathy. And between these two, the long head is much more common. If you Google this, you probably won't find much on the short head, but they do exist, and I have seen a few of them in my practice. So, what tests do you use? What does your objective exam look like? Well, obviously, you're going to look at range of motion. You're going to look at active range of motion and resisted range, so MMTs. And what you typically find is that with active range, flexion of the shoulder and functional internal rotation on the back tend to be the most painful. Shoulder extension can also be painful, but that functional internal rotation puts a pretty big stretch on the bicep tendon, and so that can be very painful. And usually, if it's a bicipital tendinopathy, flexion is going to be much worse than abduction. If it's a rotator cuff issue, almost always both are painful, but abduction's more limited. Flexion's going to be the painful one here for a bicipital tendinopathy, okay? And then I have what's called strumming the guitar strings. This is what I think about for palpating these tendons. And this is really more applicable for the long head tendon, which happens to be more common. So you find where that tendon is, the anterior shoulder. It might take a little bit for different people. You find that tendon and then you just strum over it like you're hitting a guitar string. If the patient says, "That's my pain, that's painful," in all likelihood, you're dealing with a bicipital tendinopathy, particularly of the long head here. There's no specificity with these. This has not been validated. This is just the process I use. But if I had to take a guess, you strum over that and it's painful, I would think the specificity has got to be at least 90%. It's a pretty definitive diagnosis once you have that. If it was a short head tendinopathy, you have to go into where the coracoid process is and dig in there. You will probably not be able to feel the tendon. You're not going to hit the guitar string like you can for the long head one. But if you poke in that coracoid area, really dig in there with your fingers or your thumb, and they report that's painful, more than likely it's a short head tendinopathy. Okay, so firm palpation. The next thing is a biceps brachii MMT. You just do it in the standard position. So you got here, use a dynamometer or your hand, manually resist elbow flexion, and oftentimes for a bicep tendinopathy, that is painful. Okay. It may also be weaker on the affected side, but not always. Don't assume that because you have a tendinopathy, it's weaker. It could just be painful, but not weak. All right. You're looking for the pain response, not necessarily the strength. And then we have resisted pronation and resisted supination MMTs. I like to do both hands at the same time. It's a little more efficient and it lets you feel if there's any significant weakness on either side. So what I have the patient do is hold their hands out normal like this. What I do is I cross my hands and hold their respective hands. And then what I will do first is I will turn their palms face up. That's my palms going face down, but theirs are face up. They are in the supinated position here. And then I'll say, don't let me turn your palms face down. Hold this. That would be resisted supination. The reverse, I will then turn my palms face up. Their palms are face down. And I will say, don't let me turn your palms. Keep yours face down in the pronated position. And they resist. That would be the pronation MMT. Okay. What I have found is that either of these can be painful in a bicipital tendinopathy. You would expect the supination one to be painful all the time and pronation wouldn't be. But what I actually find is that either one of these can be painful. And to be honest, I'm not exactly sure what the reason is, but it's worth it to test both of those. Really, this is all you need to diagnose somebody with a bicipital tendinopathy, a proximal tendinopathy. But there are a few other tests that you can use. There's two special tests, Speed's and Jurgensen's tests, which I cover in separate videos. I have those in my template for diagnosing this, but I really don't ever use those. You don't need these to diagnose a bicipital tendinopathy. And one of the reasons you probably should get away from Speed's and Jurgensen's tests is they can also be positive in a labral tear or a slap tear, and actually they have better specificity for that than they actually do a bicipital tendinopathy, and there's some evidence for that. So I tend to not use these, but you could potentially if you wanted to really be confident that this is what you're dealing with. One of the other ones is a biceps brachii MMT, but do it at 90-90 flexion. So rather than doing it in the standard position, you have the patient's arm up here, and you say resist, elbow flexion. If it's not provocative here, you might try it in this position, and a lot of times that one will be provocative. And if you've got all 5 of these positive, or most of them positive, especially strumming the guitar strings, you can be pretty sure that they've got a bicipital tendinopathy. So how do you treat this? Well, you don't treat this really any differently than any other shoulder condition. You find the impairments in your objective exam and then you go after them, whether it's weakness, tightness, impaired motor control, whatever it might be, go after the impairments. We no longer do this diagnosis-based treatment. There's not bicipital tendinopathy exercises. You find the impairments and you treat those. The one exception, and probably the one reason why we might want to know it's a bicipital tendinopathy and where exactly that tendinopathy is, we'll cover at the very end of this video. But let's go over these right now just very basically. Posterior shoulder and stabilizers, rhomboids, middle traps, lower traps, serratus anterior. If it's a weakness, which is most likely what it is, but it could be a motor control issue or significant muscle tightness, go after that. Thoracic spine and posture, thoracic extension and rotation tend to be limited in a lot of shoulder conditions. So go after those and mobilize and get those things moving better. And also look at the length of the latissimus dorsi and the pecs. If those are limited, that can certainly create a muscle imbalance that can lead to a tendinopathy. And then also any scapular dyskinesia. If you have scapular dyskinesia, that can cause impingement, but it can also cause the bicipital tendinopathy. And don't forget that you can have some overlap between impingement and bicipital tendinopathy. It may be that the bicep tendon is actually being impinged in the subacromial space. Don't forget that that long head tendon, as it goes up towards its origin, it actually goes through the subacromial space. So if there's scapular dyskinesia, you want to go after that. Now, in terms of the biceps, most of the time you have a bicipital tendinopathy, the biceps aren't any weaker when you do this in a manual muscle test. They're pretty equivalent in strength, it's just that there's pain. But if the bicep is weaker, you of course want to eventually strengthen it. Now, I probably wouldn't do that on day one. I'd probably go after more of these other things down here. And once the pain, severity, and irritability are down more, then go after strengthening of the biceps. But you should eventually strengthen it if it's weak. And then here's the kicker that maybe differentiates this from other shoulder conditions, and that is instrument-assisted soft tissue mobilization. Graston, A-stim, whatever you want to call it, it's all the same thing, where you scrape on the tendon. That's maybe why you'd want to know if it's a bicipital tendinopathy and which tendon, because if you're going to do A-stim on it, you want to make sure that you're hitting that tendon directly. It doesn't make any sense to go after the shoulder in general, a rotator cuff tendon, if the issue is a bicipital tendinopathy. So identify it and then potentially A-stim it and follow it up with some of these reinforcing exercises. Okay? So hopefully this video gave you a good understanding about how to diagnose and the basics of treatment for a bicipital tendinopathy. Please make sure to like this video, subscribe to my channel, and hit that notification button for notifications for all videos in the future. Thank you so much.